And we have two eminent speakers, K Oualla and Maha Hussein. Karima, you have the floor.
Je tiens tout d'abord à remercier professeur Aboulfad pour l'invitation ainsi que l'Association des urologues du Sud et le comité d'organisation. I was asked by Professor Aboulfad to give the talk in English, so I hope I will do it as well as I can do it in French. So I was tasked to talk about the genomic testing in prostate cancer. Well, I'm a medical oncologist. I will do it from the perspective of medical oncologist. I'm not a biologist. And I think it will be the bridge to the next talk by Professor Maha Hussein on the treatment, and that is driven by the biomarkers. And I can just tell you that now testing in prostate cancer is not anymore something that we can ask, secondary to the workup, but it's part of the workup, so, and as early as possible. As you know all, the pathway of androgen receptor is the major pathway in prostate cancer. But beside the prostate cancer pathway based on or driven by the androgen receptor in 60 to 70%, we do have also many other pathways that are involved, specifically the DNA repair pathway that is becoming more crucial and even guiding our practice and our treatment plan in practice. Beside this also, we do have other pathways like the PEAK3 pathways, and we will see what is the impact on treatment. As I'm therapist, and so I'm oncologist, I'm facing more and more the situation of having the biomarkers and what to do with those biomarkers once we have them in their hands and how they will change our treatment plan. So once again, so in this paper of Robinson that has been published in 2015, it has shown that we have the DNA repair defects that were identified in 23% of MCRPC, 8% of MCRPC harbor germline mutations, and we do have most of those alterations specifically regarding BRCA2. And as you know, all is different for oncologists, is different from breast cancer. It's BRCA2 that is more found and more involved in prostate cancer comparing to breast cancer, for example. What is the impact of this? Once I have this testing and I know that my patient is mutated, does it have an impact on prognosis? The short answer is yes. We do know now that the patients who are mutated can have more aggressive disease with maybe a younger onset, higher T, more node involvement, and we do also have high risk of recurrence and shorter prostate cancer specific survival, for example, for the BRCA1. So yes, it has an impact already at the prognostic level. It's interesting also to go deeper in those DNA repair defects that are, as I said, involved in 23 to 25% of prostate cancer, metastatic prostate cancer. And when we see the prevalence of germline mutations, specifically the BRCA2, and it was interesting to see this paper that has shown the prevalence of BRCA2 in different populations. You can see here you have the population from European ancestry, Spanish one, African American, and the Chinese. And we can conclude from all those populations that the BRCA2 likely to be the most prevalent germline DDR in prostate cancer. Unfortunately, we don't have very accurate data in Morocco, so we only have very small series, some retrospective works, and some studies that included many cancers, not only prostate cancer, some studies with ovarian, breast cancer, etc. So we cannot really draw very solid and robust conclusions about the prevalence or the specific prevalence of BRCA in Moroccan populations. Well, when we talk about the BRCA alterations, so we do know that we have two kinds of mutations that we have to look for. So we have the somatic ones and the germline ones. As you know, the germline mutations are inherited from parents. So basically, all cells have one mutated and one normal gene copy. So we need one additional somatic mutation to cause the loss of normal gene copy in the cell. And then so we will have the biallelic gene loss. So that is a driver for the tumor. In the other side, we can also have somatic mutations that are not inherited. They are not linked to familial background, and it's acquired during the disease or by the tumor. And in this case, so you have all the cells that have 2 normal copies of the gene, and we need a somatic mutation for monoallelic loss, then a second one to have this biallelic gene loss driving to tumor. Many mechanisms are involved when we talk about the DNA repair alterations, and the main one is the homologous recombination. And you can see here, so from this analysis from the PROFOUND study, the study that was dedicated to see the efficacy of olaparib in MCRPC comparing to RP. We have studied the samples, the tumor samples, more than 2,800, and we can see that there is various types of mutations, so mainly so the BRCA2 for the HRR, so you can see the BRCA2, then BRCA1, that we do also have the ATM, the CDK12, CHEK2, and many others, in addition to no HRR alteration detected. Always talking about those DDR genes and about their prevalence, we can see that when we focus on the general population, it looks like it's rare, it's 3%, but it moved to 6% in the high-risk localized disease and to 12% in metastatic prostate cancer. So that's why we started to get more interest in testing patients with metastatic disease, but we can see also that we can also look for this testing even for earlier stages when it's recommended. Once again, is it prognostic? Yes, you can see here that the patients with BRCA mutation, so either BRCA2 or BRCA1, they have shorter survival. So there is a high need to identify the subset of patients because we need to treat them maybe with an individualized treatment plan. Another good aspect or very interesting aspect also for looking for the genomic testing or genetic testing is that the preventive aspect, because you know if we have a germline mutation that was detected, it's mandatory to go for genetic counseling, so for the patients and for even the family. It's very interesting not only for the treatment or for the prognosis, but also for the genetic counseling and the prevention. Well, what is very interesting for us as oncologists in clinical practice is, as I said, how can we be active or efficient on those biomarkers once we find them. And you can see here that those mutations, when they are present, they give a high sensitivity to some drugs like the PARP inhibitors. We have seen that so in PROFOUND study, in many other studies. I will not go into details because I think they will be surely covered by the next talk. But you can see here clearly that there is a huge interest to identify the subset of patients with mutations, because simply when you treat them with PARP inhibitors, like here in PROFOUND study in MCRPC after progressing on RP, you have clear benefit with adding PARP inhibitors. It's also interesting to know that olaparib has the Moroccan approval, so it shows how it is interesting to test those patients because you can treat them efficiently with the appropriate drug. It's not only about finding any mutations, but sometimes also the kind of mutations can predict how will be the response to your treatment. So when we talk about PARP inhibitors, I give you the example of olaparib, but you have here in the TRITON study, the rucaparib as PARP inhibitor that was studied versus RP or versus docetaxel that showed benefit in terms of survival in favor of the PARP inhibitors, but you can see clearly that it works more and better when the patient has BRCA1 or 2 mutations comparing to ATM mutation. So we can draw a conclusion from that, that maybe the patients with ATM mutation are not good candidates for rucaparib, for example. Can we be more effective even earlier? Because what I show you was in metastatic MCRPC. Yes, the answer is shortly yes, because now we have 3 positive studies from first-line MCRPC. So I put them in one table so not be long. So the PROPEL, the magnitude, and the TALAPRO-2 with this combination in first-line MCRPC with PARP inhibitor plus RP. It can be abiraterone plus olaparib or talazoparib, enzalutamide, or niraparib. abiraterone, and you can see that the 3 studies were positive. I will not go through the characteristics and the details of the study, but I can also inform you that both combination of Propel and Talapro-2 are approved in Morocco, and they are approved regardless of the status of mutation. So maybe we can ask here, so is it worth really to go and look for those biomarkers since they will not impact the decision if I want to go for the combination? So this is debatable, but still we should go for testing. It's also interesting to see how the magnitude of benefit may be different based on the type of mutations that you have. When you see the benefit in, like here, for example, in the Propel study testing the olaparib plus abiraterone, you can see clearly that when the patient have BRCA mutations, so they have a greater benefit, the magnitude of benefit is greater, is larger, comparing to the other HRR mutations and compared to unselected patients or to non-HRR mutated. So you know if the drug should be prescribed, but also you can have an idea about the magnitude of benefit based on the type of mutation if it's present. Can we again move much earlier than the first line of MCRPC? I think today, 2026, we can say yes, because in oncology, we test drugs in general in later lines, then we move them earlier, so to earlier lines, then even sometimes to localized disease. But here, I give you shortly the Amplitude trial that showed that niraparib plus abiraterone plus castration, of course, compared to abiraterone and castration in metastatic hormone-sensitive, so not MCRPC, but hormone-sensitive metastatic disease, showed benefit in patients who harbored BRCA mutation or other also genes from the HRR mutations, type of mutations. So again, when we see another study, the Capitello 281, a phase 3 trial also that compared capivasertib plus abiraterone castration versus abiraterone castration in patients, again, with metastatic hormone-sensitive disease. With P10 loss, you can see that there is a benefit in RPFS. What does this mean? That you need to test your patient earlier, not to wait until they have metastatic resistant castration disease. So for any patient who is metastatic, he should have the testing as early as possible. Well, I don't know how those positive studies will impact the algorithm and the sequence of treatment. Maybe we will see this much better with Professor Maha Hussein, because now everything that we have in MCRPC is moving to the hormone-sensitive disease, and it will be very challenging to identify the good sequence of treatment. It's not only about the DNA repair pathway. We do also have another biomarker that is important. Maybe we talk less about immunotherapy or immune checkpoint inhibitor in prostate cancer. A very long time we considered them as cold tumors. I mean, not very immunogenic tumors, but doesn't, I mean, it's not an exclusion criteria to test those patients, especially when you ask for the NGS. So it's a whole panel where we can have the DDR genes, but also have the status of deficient mismatch repair or MSI to see if the patient can be eligible to immunotherapy after receiving the standards of care in earlier lines. We do also have data from phase 2 trial with nivo-epi, so because we have the data with pembrolizumab, and we know that pembrolizumab is independently of prostate is approved in the agnostic approach once you have a disease with MSI high deficient mismatch repair with no standard of care available to give it if the patient is eligible. But we do also have some interesting data with nivo-epi with a high rate of response exceeding 70-75% that may be interesting for those patients if we are in lack of options. Okay, so we talked about the prognostic value of testing, the role in genetic counseling, the role in sensitivity and prediction response to PARP inhibitors specifically, but not only, also to immunotherapy and to the inhibitors of the PIK3 pathways, but which genes should we test for those targeted therapies. So when we look at the guidelines, because there is a panoply of genes, a lot of genes to be tested, so what is the priority in our practice? If we want to answer shortly, so we can say that it depends on the area you are working in, because if you have the possibility to have the largest panel, it's always the best option, like having the next generation sequencing, the NGS, because it will give you a whole idea about the genes that can be alterated. But if not, and sometimes this is the case in Morocco, because I like to contextualize the things here in Morocco, because not everything in the guidelines is feasible easily here. So sometimes we can go for small panels. So by priority, like going for BRCA, BRCA1, BRCA2, MSI high also, so we consider it, so, but I mean, less importantly than, of course, BRCA1, BRCA2. And if you have to go larger for ATM, CHEK2, CDK12, PALB2, etc. So we encourage to go for larger testing anytime we can do that. Well, which are the best samples now for testing the HRR alterations? Because this is a very crucial question, because you can have false negative, have false positive, but also you can miss the right result of your sample if it's not done with high quality assays, with high quality techniques. And this is very important, because you can miss the treatment for a subset of patients just because the sample or the biopsy or the quality of the testing was not good enough. And this table shows us that we have different strategies to be considered to assess the homologous recombination alteration. So we have the three assays that we know. So we have the somatic or the tumor tissue testing, we have the plasma or ctDNA testing, and we do have also the germline testing, or so the ctDNA. For the first one, so this is the priority and the one we base on our testing's first intention. It's the gold standard for sure. It has advantages, it has also some inconvenience, but so the failure of this testing in somatic may be explained sometimes by the quality of the sample, if it's too old, or if you go for testing, for example, in an inappropriate site, like for example bone comparing to lymph nodes or other lesions. So we will see this in details. We can see here that there is a high concordance, so we can see that there is a very high concordance or correlations in DDR mutational status between the primary prostate and the metastatic tissue and ctDNA, because there is always this question in practice, should we go for the testing in the primary sample that we have in prostate, so the biopsy or the specimen of prostatectomy, or we should go to the metastasis. So it depends also sometimes on the interval and the quality of conservation of those samples. So the newest the sample is, it's always better, and for sure also the tissue. So we can see here that even in the trial, so even in profound, in Triton and high potential, you can see that we have around 30 to 50% of problems of testing just because of the quality of sample. So it's really crucial to take care of the sample that you send for genetic testing. Here also, it will confirm what I'm saying, because in the profound study, so we have seen how is the quality of the results, and if we have failure of testing or not, depending on the site, for example, depending on the site also, and depending on the interval or the age of the sample. And you can see that the old, very old, if you have a patient with a prostatectomy like 20 years ago or 15 years ago, for sure you should look. If you have a new lesion, it's preferable to go for the new lesion rather than go to the very old archived tissue or sample. This is one side. And the other side also, you can see that it's, as I said, it's preferable to go to tissue like lymph node if you have for sure the possibility, like for for N positive disease, and not do that in the bone if you have the possibility. And you can also see here that if we do the tumor-only sequencing, it can fail to detect 7% of germinal pathogenic variant in prostate cancer. So it looks like low percentage, but it's possible that the somatic testing miss some germline alterations. And that's why we should offer germline testing to patients at high risk of being carriers despite negative tumor sequencing results. The other assay or the other strategy, it's the plasma ctDNA testing. So it has also advantages. It's that it's non-invasive, it's safer, it's easy to do, but also it has disadvantages like the fraction of DNA that you can find in your sample, and that's why the best moment to do the ctDNA it's the moment of biochemical progression or radiological progression, because it will be like a screenshot of the current situation. I mean that the tumor cell will deliver those tumor cell, and so in the plasma, in the blood, and so you have high probability, high fraction of DNA to be tested. Well, what about the reliability of ctDNA comparing to biopsies or to somatic testing? You can see that also there is a high concordance between both, but you always should pay attention to those disadvantages of ctDNA. The last one is the germline testing. So specifically when you assess the familial risk, it's easy to obtain because it's sample of blood or saliva or buccal swabs, but also it can miss a high percentage of alteration that can reach 50% of HR alterations that can be missed if you do only the germline testing. So this is to conclude for the germline testing. As I said, when you compare, so the prevalence of those alterations in somatic and germline, you can see that 50% of patients can be missed and therefore not treated appropriately with the targeted therapies if the testing that was performed was only germline. Well, you can find many algorithms about how to test your patients and when to do the somatic, when to do the germline. So I just put here the ones of ASCO. But what is sure that you should test all patients with metastatic prostate cancer, not waiting to MCRPC and not waiting to later lines when you don't have any option anymore to give to your patients, because now we need the biomarkers from the hormone sensitive phase, and also we need the germline information in case of germline mutation, so because it will be very crucial and interesting for the counseling and the family counseling. So to conclude or to make it short, this algorithm, so every time you go for genomic somatic testing, so if it's positive, of course you will make a plan of treatment based on those biomarkers that are positive. But if it's negative, you should rethink about it if it will change the treatment plan. For the germline testing, for sure, when you have the somatic testing that is positive, so we can recommend also the germline to see if it's also interesting to see the family, relatives, etc. But when it's negative, it doesn't exclude a germline that your patient may harbor an alteration. So if it will change your treatment plan, you should complete with the somatic testing. So I think if we want to summarize this, there is a subset of patients that is with poorer prognosis, specifically with the BRCA1, BRCA2, since that's what we test the most here in Morocco. So we need to identify them. First, because it has a prognostic value. Second, because it will make us able to make a plan of treatment that is guided by those biomarkers, to go for PARP inhibitors or to go for other, the inhibitors of the PI3 pathways, for example, etc., or for immunotherapy. So it's crucial to have those biomarkers, but it's also very crucial to insist on the fact that all your patients with prostate cancer should be tested, and it's even more crucial to have a very high quality sample to not fail your testing. And with this, I can say that we came a long way for prostate cancer, so from EDT as the only option to nowadays very complex algorithms, but it's with better outcomes for our patients, and for sure the future is even more bright for the patients with prostate cancer in the future. Thank you.
Thank you very, Karima, for the excellent presentation.